Allen from the Department of Health to speak to us today, and I appreciate your patience as we do our NAMI thing. Greg is the Director of Program Development and Management for the Office of Health Insurance Programs at the Department of Health, and one of his most important duties is working on the implementation of the Health Homes Initiative. Now, as I've gone around the state meeting with different groups, this is something that comes up regularly. People ask a lot of questions. People call me on the phone and ask about it. I hear about this all across the state, and one of the things that I thought was, with this conference, this is a great opportunity to bring a true expert here to meet with us all. So please, this is Greg Allen, and he's going to talk to us about health homes.
Thank you very much, Don, and thank you all for being willing to listen to a state guy talk to you about a state program after you've just enjoyed your lunch. I'm going to go really fast, blissfully, and I just want to give you a little taste about what we're trying to do for care management for the highest need and highest risk folks that are enrolled in our state's Medicaid program. And I'm going to try really to focus as best I can on those individuals who have needs in the mental illness spectrum. Talk just a little bit about what might be currently broken and how we see this fabulous opportunity to build health homes, and in this case a behavioral health focused health home, to really leverage federal dollars to accomplish better care management. And not only accomplish better care management, but also try to integrate care a little bit better. And I think this becomes critically important as we see more and more research out there showing that individuals dealing with mental illnesses having increased morbidity and mortality rates. And it just seems like we can't get through another quarter without a study coming out and saying that folks with individuals with mental illness really are having significant struggles, and not just with dealing with the mental illness, but importantly with dealing with physical complications. And those physical complications resulting in compromised lifestyle and importantly in earlier death. And this, I think, is just really a rallying cry for all of us that we just have to figure out. Have to. It's not a question of this would be nice. We have to figure out how to integrate behavioral health care with physical medicine in a more meaningful way. If we do not do that, I'm afraid we're just going to keep watching more and more sad stories, worse and worse numbers coming out. And I believe so much of this is preventable. This is not about not having the resources, the technology, or the money to solve this crisis. This really is about orchestrating existing resources in a meaningful way to bring comprehensive physical medicine into the mental illness spectrum, bring the expertise that exists in the mental illness world into the physical medicine world. This cannot be done by a psychiatrist by him or herself. This cannot be done by a counselor by him or herself. This cannot be done by an individual's primary medical doctor by him or herself. This cannot be done by the specialty nurse by him or herself. This cannot be done by the patient or their family by him or herself. This is going to require all of those entities and more, including people providing housing services, social services, physical medicine, behavioral health services, all working together with a patient focus in order to solve this crisis. And what I'm about to show you really is, I think, our first chance to pull all this together in an orchestrated, meaningful way with one basic goal, as we're talking about this as it relates to mental illness. It also relates to addiction. It also relates to multiple chronic medical conditions as well. But when we talk about it related to mental illness, it's got one purpose. And that one purpose is to bring all of those various entities together with one person accountable for orchestrating all of those pieces to try to improve health. And health includes both mental health and physical health care. And to think about that not as two separate ends of a completely disparate continuum with siloed care that you as family members are left to manage by yourselves, but to really try to create resources in the community to bring that care together and to have a single individual responsible for that care. That's what a health home is supposed to be. It's supposed to be help for a person that has multiple chronic illnesses, including mental illness, to navigate the physical health care and the behavioral health care system and all the wraparound social services in a way that will bend this needle backwards in terms of early death for people with mental illness. That, I would just argue, should be our most important thing that we focus on, is to allow people with mental illness to lead the same kind of healthy lives that people that don't have mental illness do, to the full extent possible. And that's really what we want to ultimately build with the health homes. So I apologize for the color of the projection here. But we have, the feds told us that we can do, oh, if you could advance it, it'd be great. Then you have to see my head blinding through the slides. And I'll leave this slides set with you so you can email it around or provide paper copies. I apologize, I didn't do that in advance. This slide basically says that the federal government said for our first phase that we're ready to go on health homes. If you could do the next slide, please. I promise to go fast, and I will. These are the phase 1 counties that we're bringing health homes up. And for those of you over there, I'll read them. It's Bronx, Brooklyn, Nassau, Schenectady, Washington County, Hamilton, Clinton County, Franklin, Warren, and Essex. We moved Rensselaer, Albany, and Saratoga to later phases based on provider readiness. This means that this program of comprehensive care management will be available very, very shortly in the counties that I just read off. Next slide, please. So this is our health home population. Oh, and it looks great on a brown wall. I like this. So anyway, I'll survive this. There's about 975,000 people, that's almost 1 million people that meet health home criteria by the way that we've interpreted this. Multiple chronic illness includes behavioral health care. That's almost 1 million people out of the 5 million people served in Medicaid have multiple chronic illness, including behavioral health. We put them into 4 categories, if you will. Those with developmental disabilities, there's about 52,000 of those folks, and then we stripped them out and we looked at people with more than 120 days need for long-term care. That includes personal care, home care, nursing home care. That's about 209,000 recipients. And then importantly, we get down to our 3rd quadrant. These are people that don't have developmental disabilities, not in long-term care, but either have mental illness or substance abuse as part of their diagnostic profile. And that's about 408,000 patients. And right now we're spending $6.3 billion on those individuals, much of that related to disparate, non-coordinated care. About 16% of them also participate in the Medicare program, so that means they're in Medicaid and Medicare. And right now about 61% of them are in our state's Medicaid managed care program, so that becomes important to this. And then there's another 300,000 folks that didn't meet any of the other 3 criteria for multiple chronic illness, but they had multiple medical illnesses. So you go to the next slide. So this is really easy to read, so it's self-explanatory. This is it kind of looks like you're looking out the window on a very snowy day, doesn't it? This just basically says, I'll give you this take-home message, that many of these individuals that are meeting this definition, when we look at the most frequent diagnosis, the top is schizophrenia. The second one is schizophrenia with other dominant chronic medical disease. So our first 2 diagnoses for our behavioral health cohort, if you will, are schizophrenia, and then the second one is schizophrenia with another medical condition attached to it. And as you go down the list, you're going to see bipolar disorder, depressive illness, HIV disease, most of them mixed with other chronic medical illnesses. So this basically, right off the bat, just shows us that if we are going to manage people with mental illness, especially those that have multiple problems, we have to bring the physical healthcare community together with the mental illness community. And if we don't do that, we can't provide good care. And I'm sure each of you could tell a story about how the care is fragmented between the doctor's office and the psychiatrist's office, or the mental health clinic and the specialty services that you're trying to do. And that very often, even if you've got an assigned care manager, that they're frustrated by helping you get to immediate appointments that you might need on the physical healthcare side. So part of this is just all about beginning to focus on people with multiple illnesses and provide care management to them that also is built into a structure where the doctor, the psychiatrist, the mental illness professional are all working together. So if you would just flash through here, this slide basically says when we looked at our sickest patients in our chronic illness demonstration that we ran before we did health homes, about 66% or 2/3 of them had mental illness. I'm sure you can pull that out of the chart. You can see the 66% there, right? But as we come across that 2/3, we see that about, I'm going to try to read this to myself here, but about a half of them are hypertensive, meaning they have heart issues. Another third of them have diabetes. Almost 40% of them have asthma. They're having fun. And I think it's about a fifth of them have chronic obstructive pulmonary disease or serious breathing problems. So if we're going to solve the issue of high-risk, high-cost, medically complicated folks, even focusing just on that cohort that has mental illness, we have to bring doctors and nurses in the physical healthcare community into this work. So I'm going to actually, there's more slides in here on children. There's some additional slides on what we're doing on confidentiality, but I just want to hit a couple more points and then I will turn the microphone over to the rest of your program, and I want to thank you for your patience with these easy to read slides. And that is that really what health homes are is a way to provide care management. The dollars that are going to flow out through the health homes are going to support a care manager. Many of you may already be engaged with a targeted case management program as part of the services that are currently provided by the Office of Mental Health. We are in the process of transitioning those care management services into health homes. So those will not go away. We're not changing patients' care managers. We are working really hard to even pay the same rates to make sure that patients that are engaged in current care management programs get brought into health home programs very carefully. Our number one rule as we're rolling out health homes is not to disrupt the good things that are happening right now in the targeted case management programs that many of you or your family members may be engaged in. And we're critically connected to the Office of Mental Health on making sure that that happens. But what we're going to try to do is provide some more flexibility. So fewer minimum standards in terms of contacts. We're going to let people do more or less service based on what patients need in a given time. We're going to manage quality metrics. We're going to see, are people staying out of the emergency department? Are they staying out of the inpatient bed? Are they keep taking their medication on time? If issues are coming, the people that are trying to listen are asking you to please be a little quieter. I know it's exciting, probably. I mean, I actually think it might be helpful if they don't have to hear me, but it sounds like at least a few people are somewhat interested. So the goal of all of this is to, instead of focusing on process, like how many times does somebody meet face-to-face with a care manager, let's all focus on outcomes. Can we keep people out of the inpatient bed? And if there's a care management agency that's doing a poor job with helping people achieve medication compliance in a meaningful way, that's keeping them out of the emergency department or the inpatient program, then this health home, this single point of accountability is going to really think hard about assigning new patients to that program and may think about giving patients choices to get to a program that's doing a better job with that. On the other end of the scale, for those care managers who seem to be doing a great job with keeping people out of the hospital, we may be asking that program to take on more patients. So really what this is an opportunity to do is to measure the outcome of care management rather than just the process. Put more dollars into it and also require that the mental health providers and the physical health care providers that are in the health home network, that they work together. That they work together with two main goals in mind. And those two main goals are keep people out of the hospital and improve their health. And I've got a lot of quality metrics that I won't go through because it's going to be, again, seeing them in a snowy window on a rainy day or something. But I want you to know that this is a patient-centered model that really, in the end of the day, we are going to try to improve care. And we're doing it statewide. We're done with demoing it. We're going to roll it out. But in the process of this, Our main goal is to do no harm to the existing care management. We're just really, really working very hard to make it better.